Hi, I'm Dr. Tomas Grippo and want to welcome you to the first consensus on MicroPulse TLT. I would like to thank the expert panel for all of their hard work over the past several months to make this a reality. I would also like to thank Iridex for facilitating the logistics, resources, and for allowing this to be a content-independent, physician-driven consensus. Finally, I would also like to thank you, the audience, for joining us today. I'm going to talk about an overview of the MicroPulse TLT consensus. So what is the consensus main objective? It is to provide an independent, peer-driven, contemporary clinical guidance on the use and indications of the revised MicroPulse P3 Probe and Cyclo G6 laser system for the treatment of glaucoma. It's important to highlight that Iridex was not privy to the questionnaires, initial responses, or final responses until a consensus was reached and had no input on the findings or guidance being communicated. Treatment guidance and recommendations are based on expert opinion. In practice, the treatment parameters and patient selected are the sole responsibility of the treating physician. When it comes to the methodology, 10 glaucoma specialists with significant experience performing MicroPulse TLT from the United States, Argentina, and Europe were invited to participate. Scientific evidence was gathered from 61 publications indexed in PubMed on the following topics: knowledge to date, patient selection, pre-op anesthesia, treatment, dosing, post-op care, clinical outcomes, potential complications, and treatment enhancements. For this webinar, we will focus on patient selection and dosing. To reach consensus on these topics, a Delphi method approach was used when there was limited published literature. This included 3 rounds of survey questions that were held between September and October of this year. A virtual consensus meeting was then performed to present the findings and gain consensus. The pre-final step is to present the outcome of the consensus process to the scientific community during this webinar today. And the final step will be to publish it in a peer review journal. So when it comes to the structure of this webinar, it will include the presentation of 16 consensus questions and findings following a logical progressive sequence. This will highlight dosimetry concepts, recommended settings, and patient selection. It will include 3 case presentations and discussions on using the revised probe in patients with mild glaucoma, moderate glaucoma, and severe glaucoma. Finally, there will be closing remarks and the announcements of the next consensus chapter event. Of note, because of time limitations, there will be no live question and answer session with the audience. However, we invite you to please submit your questions via email at info@iridex.com. These questions will be answered by email after the webinar. So now I would like to introduce Dr. Robert Noeckert, who's a renowned glaucoma specialist and an assistant professor at Yale University.
Thanks, Tom. And thanks everybody once again for tuning in here on Saturday. And so what I'll do now is introduce, once again, we've kind of broken down to the main 16 points that we came away from with our consensus panel. So as Nate's loading up to share his screen with us to do the first question, I'll introduce him. Nate's from New York. He's right now an associate clinical professor at Mount Sinai, and he also works at the New York Eye and Ear infirmary in New York Eye Surgery Centers. And Nate has a lot of experience. He's one of the early investigators in this new technology. And I'll let him kick it off with question 1. Thanks, Nate.
So yeah, and it's been a fun adventure. I think it was about 2014 when you and I, started along this pathway, and this has never been a dull moment, and we've learned a lot. The question that came to me is, does the amount of energy applied have an effect on IOP reduction and the duration of effect? And we do believe that the amount and duration both have an effect. The amount of laser energy applied determines if an effect is achieved. So in order to get the effect of pressure lowering, you need to hit a certain amount of energy. And it also has some influence on the duration of pressure lowering. Once a good effect is achieved, my experience has always been that the duration goes for a very long time, if not indefinitely. Low total energy results in a lack of efficacy or sustainability, and you do have more lasting effects the more energy you use. And Sanchez and colleagues, including a few folks here on our panel, looked at 22 eyes, 17 patients with glaucoma of various types and stages, followed them for 7.9 months on average. And all patients got 2 watts of power at the typical duty cycle, 31.3%, but the treatment duration varied from 100 to 180 seconds. And as you can see, those eyes that had the higher amount of or longer duration of therapy ended up having a sustained success and achieving about 80% success, up to the end of the study period. Whereas eyes that received 100 seconds or somewhere in between didn't have either as high a responder rate or as long of an effect. So that's the lesson from there. Success was defined as it typically is, 20% pressure reduction, not in a hypotony zone and no secondary surgery. And you got the 75% successful with 180 seconds, 21% successful with 160, and no real sustained success with 100 seconds only. So we think there's a threshold that 180 seconds was a good place to go. And most importantly, the higher amount of energy didn't create any problems in terms of safety. So no complications. So that's one piece of information. A little bit of this, now we'll kind of look at the work of Murray Johnstone and just talk a little bit about how the laser works. It causes contraction of the longitudinal ciliary muscle fibers, specifically the longitudinal ones. That tightens a scleral spur, results in a possible prevention or opening up of the canal, preventing collapse or opening it up. And have some kind of nice images from the work of Dr. Johnstone here. So we're looking at a cadaver eye, and you can see the contraction of those longitudinal fibers as the laser is applied. And it's quite remarkable in this experimental setting. This is obviously the probe being placed against the sclera, and you're seeing the action on the ciliary body below. Dr. Johnstone concluded that ciliary body motion begins to occur at very low energy levels, and ciliary bundles shorten and then lengthen again. So there's sort of an interaction between the laser tissue, and MicroPulse laser causes the contraction. And ciliary muscle bundles only partially lengthen. The thermal effects are going to be long lasting, and the tissue changes are confined to the longitudinal part of the muscle. And he does not see the ciliary epithelium being involved in the MicroPulse in any of his studies, indicating that we are treating here the ciliary muscle, specifically the longitudinal fibers, and that we're getting a pilocarpine-like effect, and that we're opening the angle. So this is an outflow mechanism, or at least for Johnstone's work. Finally, I talked about varying the duration of therapy, but there's another way to change your power settings, which is to go up in the power. Now, this was, again, with the first probe that came out, but I treated a number of patients and found that there's 73 patients, all of them followed for over a year. I used 100 seconds total, which I recognize is a shorter amount of time than you've seen in other studies. But I varied the power by going up. And when I used a higher setting of 2,500 milliwatts, I got 57% pressure reduction on average, and I got a 30% reduction at 2,000 milliwatts, indicating that there was, in fact, a dose response curve to the amount of energy. Again, just on average, I got the pressure from about 26 down to, say, 15 or so. And again, this is out to 2 years. And you can see that really good stability between 1 month and 2 years. This is the dose response showing that I had the highest amount of response with 2,500 milliwatts, that 2,250 and 2,400 were somewhere in between, and that 2,000 got me, that sort of 20 to 30% pressure reduction, but clearly wasn't as efficacious as 2,500. So we know there's a dose response curve related to both the duration of treatment as well as the total energy. And again, that dose response curve was present from 1 month, 3 to 6 months, and out to a year. So summarizing, we know that longer duration increases efficacy without a safety cost. Higher energy aids efficacy, and that response is present 1 to 2 years later. Dr. Johnstone has shown that this is an anatomical change and not something that we're doing to reduce aqueous production on the ciliary body epithelium. There is a lower limit of energy, and if you don't get above that threshold, you may not get a pressure lowering effect. And this could be because the total energy is too low to get the threshold of tissue impact. As Dr. Johnstone showed, we want to get those longitudinal ciliary muscle fibers. And when we are sub-threshold, we may have a reversible effect that doesn't stay. Thank you, Rob.
Thanks, Nate. That was great. And so as Jella shares her screen, we'll transition you over. So Nate, do you think that you that was a trend or treating more aggressively? Were those higher power, those higher energy patients later treated, or were they all kind of from the beginning?
I do vary it to, like, for example, a number of those higher power patients were on oral Diamox. So I tend to use the more aggressive settings for more severe disease, higher pressures, and more medication burden. Whereas I have no hesitation for 20/20 to use the 2000 setting. Now, that was with the first laser. I've sort of moved all my power up a little bit with the second laser, as I'm sure we'll get a chance to discuss. And there's also remarkable safety with the revised probe, so you can feel more confident and even be a little bit more aggressive with your settings now, because we're really getting just such safe effect with the new treatments.
Great, and I think all those comments prime the pump for our later discussions. Thanks, Nate. That was great.
Thank you.
So, Noah Ons at Hopkins, rising star in glaucoma. Take it away, Dr. On.
Thank you. So the question that I've been trying to answer has been, is there a sweet spot for the parameter used in MicroPulse to achieve the good efficacy while maintaining the excellent safety profile? So based on the literature, with mostly the original probe, unfortunately the new probes have been only out for a year or two. So most of the studies that we have is with the original probe with a little bit of a lower setting. But it seems like the range of the energy application from 150 joules to 200 joules of total energy, usually applied with the 10-second sweeps per hemisphere, appears to balance the good IOP reduction with limited side effects. So I'll show you here, same study, the same author, Sanchez group, did this very, very valuable literature review to show that most of the studies that use the energy between 112 joules to 150 joule, they seem to get about 30% moderate IOP reduction with almost no complication for at least 12 months. Now, Nate talked about Murray Johnston's study on the pilocarpine-like effect that MicroPulse seems to induce. So where does that kind of max out? And this study actually showed, just investigating onto that study showed that pilocarpine-like effect kind of maxed out at 150 joule. And most studies that use the 150 max joule didn't seem to have much of a complication. So it makes sense to use at least that much of an energy, total energy, to have the most effect on the ciliary body. Now, those studies that use a little bit higher energy settings, so above 200 joules of a total energy, they seem to have more moderate to severe complications. So it may be because of, at that energy setting, we may be inducing more of a cycle of photocoagulation, just like those continuous CPC laser would do. Just so that everyone's aware, the total energy in joule is calculated by the total treatment time in second times the power in watts times the duty cycle for MicroPulse, which is 31.3%. Here's a more recent clinical evidence. Lim's group published a case series of a repeat MicroPulse TLT in patients with the advanced glaucoma. In this group, 42% were NVG patients. So these are very tough group. So what they show is that if you use a less than 150 joules total energy, you get a limited response. If you use more than 200 joules, you don't really get any IOP reduction or clinically significant IOP reduction. So this is one of the first reports to show the maximal response, even though this patient population was a pretty refractory. Now here's another recent prospective study of 52 eyes, mostly Caucasian with the glaucoma. Their mean baseline IOP was 32.6 millimeters of mercury, and they used the original P3 Probe and maintained a 2 watts of power, 31.3% duty cycle, 10-second sweeps per hemisphere for all of the eyes. And their results showed that the greater IOP reduction, so up to 40% mean IOP reduction at 18 months, while using the total energy of 200 joules versus 150 joule, where they had a 30.8% reduction. So very similar to that congregated data that Sanchez group reported. It's important to keep in mind that there are other variables that may significantly affect the outcome, such as how efficiently the heat energy is delivered to the target tissue and the amount of the heat energy, which is reflected by the parameter called affluence. So Mike and Tom will now explain more about that concept.
Thanks so much, Jella. That was great. So do you think there's a sweet spot?
There is a sweet spot. So we'll go into more detail. So the sweet spot is really between 150 to 200 joule total energy.
Good, perfect. Tom, you ready? You got your slides loaded up? So our next taking up the next question here is Thomas Grippo. He's in Buenos Aires. I first met him when he was here in the United States in Yale, but now he's kind of the king of glaucoma for South America. At least that's what I think. And the other thing is that there's no one in the world who cares as much about fluence as Dr. Grippo. Take it away, Tom.
All right, thank you, Rob. So the question I was asked is, are fluence and total treatment time taken together the most representative parameters to reflect the amount of energy delivered to the eye during the MicroPulse TLT treatment? So the consensus statement is that fluence is a parameter that takes into account power, sweep velocity, and duty cycle, and shows better correlation with efficacy compared to total energy. Fluence and total treatment time, which is number of sweeps times duration of sweeps, are both components to be taken into account when performing MicroPulse TLT, as they incorporate all treatment variables relevant to therapy. So let me review now how we got here. So when it comes to performing MicroPulse TLT, there are several variables that we are keeping in mind. One is power. The other one is duty cycle. The other one is total treatment time, which is the number of sweeps that we do and how long each sweep lasts. Then we have sweep velocity, which is how fast we do our sweeps, and then the area treated. So when we look at the formula of total energy is power times duty cycle times duration of treatment. So we are actually leaving outside of the equation, mainly, most importantly, sweep velocity. And sweep velocity, like Jella was saying, has a lot to do with how much energy we are depositing at a specific part of the eye when we do the procedure. So the fluence formula is power times duty cycle times dwell time over area. And dwell time is the equivalent of standing in place, pulse duration, during which the same amount of energy is deposited per segment during the sweep. And the equation of dwell time includes the size of the probe divided by the arc length times the time of the sweep. So the fluence equation really includes power, duty cycle, sweep duration, sweep velocity, and area treated. So fluence for MicroPulse TLT, fluence expressed in joules per square centimeter, is a better surrogate for a sweeping motion application of energy like we do with MicroPulse TLT. It takes into account all of the parameters I just highlighted, with the exception of the total number of sweeps. And just this year, we published this paper where, we analyzed the published literature and found out that less than 14% of the published papers would specify the sweep velocity of each pass. For those papers that described all parameters involved in MicroPulse TLT, we calculated fluence and total energy and compared them against IOP reduction. And when it comes to the results, we look at figure 1. On the x-axis, you have total energy for those cohorts that we analyzed. And on the y-axis, you have IOP reduction. All the dots within the figure represent each cohort that we analyzed. And when you look at it, you can see that there is no apparent relationship or trend. Now, on the contrary, in figure 2, which represents IOP reduction versus fluence for the same cohorts, we can see a positive trend, implying that fluence may be a more accurate way of measuring energy delivered to the eye during MicroPulse TLT. So taking it all together, dose means, and going back a little bit to traditional medicine, dose means a quantity of a medicine or drug taken at a particular time. Frequency means the number of times a substance is administered within a specific time period. And this is how I like to see MicroPulse. The dose may be thought as the equivalent of fluence, and the frequency may be equivalent to the number of sweeps, which when taken together will ultimately give you the amount of energy delivered to the eye and the therapeutic effect of your MicroPulse TLT treatment. So going back to our consensus statement, fluence is a parameter that takes into account power, sweep velocity, duty cycle, and shows better correlation with efficacy compared to total energy. Fluence and total treatment time, meaning the number of sweeps times the duration of the sweeps, are both components to be taken into account when performing MicroPulse TLT, as they incorporate all treatment variables relevant to therapy. Thank you.
Thanks, Tom. So just to bring it home, what parameter on the machine do you change, or in your treatment, what do you change to influence fluence when you treat? What have you changed?
Well, I think we will be addressing that on subsequent questions, But if we look at what Jella was mentioning at the very beginning on the MicroPulse TLT literature with the original probe, most of us were doing 10-second sweeps. And we will see what the consensus recommendation is, but there's probably a big change on the sweep velocity of our passes. But let's go to the next points to better understand your question and the ultimate answer, Rob.
Mike Javingo, you ready? So yeah, so I think the biggest thing that we've changed, that we can influence is sweep velocity, as you kind of said. So I think that'll come up over and over again. But I think these are some of the highlights you want to hit. Ready, Mike? Mike comes to us from Cook County in Chicago, where he's in the trenches. He probably has one of the most difficult glaucoma practices going, right, Mike?
Well, yeah, we try. We get some pretty interesting cases coming in on a daily basis. So thank you, everybody, for joining us. I have the fourth question among a few others. So this is the first one. On the original MicroPulse P3 probe, what are the most frequently published values of total energy, fluence, sweep velocity, duration, and total treatment time? And what are the expected outcomes with such values used? So we basically did a literature search looking through the most published values for each of these topics, which, as we've gone through everything, each one of these parameters gives us a different piece of the puzzle. So what we found was the upper and lower boundaries most commonly used in the literature were where all the parameters were described when using the MicroPulse, the original MicroPulse P3 probe, are between 62 and 200 joules of total energy and a fluence value between 52.4 joules per centimeter squared and 69.2 joules per centimeter squared. The treatment duration per hemisphere ranged between 50 and 160 seconds per hemisphere, with a mean of 86.7 seconds. The most frequently used as sweep velocity was 10-second sweeps per hemisphere. Again, as we've discussed before, a lot of the original literature did not focus on sweep velocity, so a lot of it's not published, and Dr. Grippo did a lot of the legwork in looking into and trying to find out what most of these individuals were using. When using these parameters, the clinician can expect an initial significant IOP reduction, which in most cases is sustained over time with a good safety profile. My 2 cents on we, for the most part, started off in the 80, 90, 100 second treatment time per hemisphere. A lot of the literature, especially looking at Sanchez et al., showed that the lower treatment times, the 50, 60 seconds, had a little bit of a lower IOP reduction for a less sustained period of time. And we'll talk more about the sweep velocity, but this was a topic brought up by a lot of different people, including a name that you're going to hear multiple times, Dr. Johnstone, during this talk. But the 10-second sweep time, again, was something that I was one of the ones who also started this in 2014, where the first few years we didn't even really concentrate on that because nobody really gave it too much thought. And then we went on to 10 seconds. And then one of my further questions, we'll talk a little bit more about why that's such an important parameter. And it seems that increasing your sweep time definitely improves your outcomes. And then Dr. Ratcliffe's work, again, looking at the power, all three are very important parameters, going from 2000 all the way to 2500 per his paper. And we'll talk a little bit more about the recommended power for the revised probe. But most people are using around 2500 milliwatts currently. So, and then we'll move on to the next question.
All right. Thanks, Mike. That was great. So next we'll hear from Mark Toderberg from Zurich. You ready, Mark?
I am. Let me just put my slide on.
Of course. So Dr. Toderberg is one of has done a tremendous amount of work with MicroPulse, and he'll take the next question for us.
So next question is basically going on, and based on the other questions before, have we already reached the upper boundary of energy delivered that allows us for maximal therapeutic response with an acceptable safety profile? So what we all want to have is like a treatment where we have the maximum effect, but still want to achieve a good safety profile. And well, the evidence is that some in the literature included several enhancements over time. Have been reported with few side effects in general. So highlighting the sustainability of the efficacy over time is more of an issue than safety with the current parameters. And it's proposed that higher energy delivered to the eye causes more lasting effects. Therefore, it is important to revisit how the upper energy boundaries of MicroPulse TLT are defined. So what does it mean? It means basically like we still can enhance treatment efficacy by enhancing the energy delivered to the tissue while still achieving a good safety profile. And in addition, what we have found by the literature is that sleep velocity and fluence have been found to be more accurate measures for the treatment dose than all the other parameters talked and reported before. So my personal experience, to talk a little bit about that, we all use the same duty cycle. I maybe use a little less energy than a lot of other colleagues, 2000 milliwatts only. And when I started initially with the MP-TLT settings, I also used 10-second swipes, 60 seconds per hemisphere. I didn't change the energy in the beginning, but I changed the time. So I went over to treating 80 seconds per hemisphere, and only my efficacy changed marginally by that. So 20 seconds in addition, but the efficacy was kind of the same than before. What I do now is, and that's what most of us do, is I changed the sweep velocity. So I went down from 10-second sweeps to 20-second sweeps. So longer time per sweep gave me a much better efficacy as a result to the treatment. So to summarize that, we may be still under treating and the upper range is still to be defined. All panel members agreed it is possible to increase dosing, that means energy delivery to the treated tissue, and thereby increase IOP reduction, which is efficacy, and or duration of the effect, while still maintaining the safety profile.
Good. So Mark, if you could hit the, how high would you turn the machine up for some patients, like your worst patients? What would be the upper end, do you think? Just quickly your opinion while Brian's getting set up here.
That's a good question. So I have some patients where I increase the energy from 2000 to 2500 milliwatts. And I also have patients where I still go with the 20-second sweeps, but the time that I treat per hemisphere is much higher. For example, neovascular glaucoma, where we all know that we have, well, not only with MP-TLT, but with all treatments, not really great results. I treat much longer, like maybe 200, 120 seconds in total per hemisphere. So I think that's, for me, is still my personal highest limit that I treat with, but still having with these settings not found much worse safety profile. So I still think we can add some more and still remain the safety. So I think we are not there yet with the upper boundaries. On the other hand, we all probably agree that we don't know them because there was no study done that tested all the different parameters in a big group, which will end up in a giant study by population that you need for that, to test all the parameters and see which actually is the setting as a higher boundary that we can use when the safety profile will get worse, and we have to worry about that.
That's great. And we'll talk a little bit more about it in the future, but thank you. I think I'm right there with you. All right, next we have Brian Francis, who comes to us from Doheny, now part of UCLA in California. Good morning, Dr. Francis.
Thank you, Rob. Still morning here. Yep. Thanks for the panelists and everyone for logging in today. My first question is a little bit about the differences between the version 1, the original MicroPulse P3 probe, and the revised P3 probe. Specifically, what are the differences in energy delivery and safety, but also how does this affect the way we treat patients with the different probes? So the panel consensus was that when it comes to energy delivery of the original MicroPulse P3 probe compared to the revised probe, the panel members found that they use higher energy with the revised probe in, for instance, higher power and slower sweep velocity, as you've heard. The revised MicroPulse P3 probe also allows for a more consistent treatment and reduces the side effects associated with an anterior treatment versus a proper posterior treatment. And so we're going to highlight a couple of the differences in the probe design that affect these parameters. So first of all, you see on the left the version 1 probe. It has a rounded tip, which makes it not sit on the eye. It can sometimes rock on the eye because it's not fitted to the surface of the eye. And therefore, that can lead to sometimes more anterior delivery and some of the increased complications that you can see, such as inflammation and increased pupillary size. The version 2 probe on the right, by contrast, has a concave tip, which sits on the surface of the eye and keeps it a little bit more in place and directs that delivery of the laser energy more posteriorly where you want to see it. And we think that that has an effect on the type of complications that you see with the delivery being too anterior. Going back to the version 1 probe, if you notice on the bottom part here, it has a small portion here with a little bulb at the tip, which is the end of the laser part of the device. And that tip does indent the globe when you press on the globe and do your sweeps. And that may actually give you more laser energy delivery, even at a lower energy power level. As you can see on the right side, there's that concave tip surface has a smooth interface with no indentation. So when pressing on the globe, it does not really indent the globe in that part where the laser energy is being delivered. And therefore, we believe that the energy delivery is more uniform and is less than you're getting with the version 1 probe with similar treatment parameters. So I just want to show you, this is a patient being treated with the version 1 probe, and we'll go over a quick case study on the version 2 probe. So this is a 78-year-old male with severe ocular surface disease with OCP and secondary glaucoma. Advanced cupping, pressure is greater than 20 on maximum medications, has a keratoprosthesis, and most importantly, he has no room in here for treatment. He has both a medial and a lateral tarsorrhaphy and very limited surgical options. So we could not treat this patient with the version 1 probe, but with the version 2 probe, you can see we're able to get in there, and because the foot plate of the probe is smaller, we're able to get it in there and do a full 360 treatment on this patient, both superior and inferior. And so not only does the version 2 probe change the power settings that we do and gives you more consistent energy delivery to the posterior area rather than anterior area, we believe it decreases complications and it makes it more versatile in patients' extreme cases such as this. Okay, thank you.
Thanks, Brian. So let me ask you all, I am trying to get my stuff up. Is when would you use the old probe versus, can you find any reason why you would use the old probe versus a new probe?
No, just using up your old stock, I guess.
Good enough. All right. So I'm Rob Noeckert. I'm a tertiary glaucoma guy here up in Connecticut. I teach at Yale and at Quinnipiac universities. And my question is really, I think, in some ways, one of the takeaway messages here, besides probably slow down the sweep speed, is what's our recommended. And there's limited literature on using the new probe so far. So this is really a panel consensus. But I think, the duty cycle, which is we've been using before, 31.3% duty cycle, 4 sweeps of 20 seconds per hemisphere. Or if you break it down into quadrants, that's 4 sweeps of 10 seconds for each quadrant. And for 2.5 watts. And so I think that's really, for me, I mean, this is a consensus, but more and more, if we're kind of like playing with these different clinical scenarios, I used to think that I varied it much more, but I would say these settings, in my opinion, we can certainly talk more as a group, apply for most of the patients I think we treat. And really, I think the question more often than not is maybe why would you make changes to the settings? I think when in doubt, my recommendation to anyone would start to these settings. If there's a reason to move it down, which we'll have cases later on, that's what we'll do. So I think always using this as a starting point versus a minimum is we're starting in the middle and then we move up or down depending on the clinical scenario. Maybe it's retreatment, other risk factors. So that's, I think, really the biggest takeaway point. And the other consensus is if we do think there has to be an adjustment, you should probably make it relatively substantial where you're changing the energy delivered by 20 to 25%. Little bumps up here and there probably are not clinically meaningful. So once again, starting the sweet spots, 2.5 watts, 20-second sweep seems to be the new consensus for timing. We keep the duty cycle the same, and usually about four sweeps, about 80 seconds per hemisphere. So once again, I think that's the takeaway consensus opinion. And next up we have Mike. Anybody want to pipe in? Anybody have a differing opinion while we're waiting for Mike to get his next question up?
And one thing, Rob, that I think it's important to highlight is, let's go back to your last slide.
Not going to happen.
All right. Well, basically that you can, we agree that you can adjust when you want to go up or down, 20, 25%, that you can achieve with, decreasing the power or slowing or going faster with your sweep velocity, or even changing the total treatment time, right? And that goes back to the question you had asked me like a little bit ago. That would be the answer.
All right, excellent. All right, now we have Mike Javingo back for question 8 here.
Okay, so moving along, the next question I had is, what is the most important variable for MicroPulse TLT that has been underappreciated in the literature and in practice? I think that, the main part of this question is the underappreciated part. All 3 parameters are extremely important. And as we've been, as clinicians, trying to titrate up and find that quote unquote sweet spot, we've been working through all 3, mainly the treatment time, the power, the sweep velocity. But given the questions asking the underappreciated one, and again, as I said before, it's been a pretty long time going that nobody really gave it any thought as far as the sweep time. So most of the panel members agreed that the sweep velocity is a significant factor to consider. And one of the main reasons, just looking at this, that, one, it's underappreciated, but 2, why it is having such an effect on the intraocular pressure. It gives you uniformity. You're able to, not to give yourself the predictable outcomes by applying the same amount of laser to the same area. Going back to Dr. Grippo's article, the Fluence publication, Fluence equals power times duty cycle times dwell time over area. When we actually analyze this, the dwell time is a direct factor in this. So if we are increasing our dwell time from 10 seconds to 20 seconds, when we're talking purely in hemispheres, we are actually doubling our fluence. So we're applying, the amount of energy that we're giving to a certain area is doubling, well, in fluence, so joules per centimeter squared. So that has had a significant effect, and all of the clinicians here agreed that there was a significant improvement in our pressure outcomes, predictability, and the fact that you kind of, you get the same pressure lowering per patient. The other thing to steal from Dr. Grippo's article, and I thanked him for this one, this is a good idea. How you can think of fluence is basically when you're waving your finger in and out of a candle. If you're moving it really fast, you don't get any burn on your finger. You might get a little bit of soot, a little singe as you're starting to slow. And as you go slower and slower, more energy is delivered to your finger. And very much in the same way, when we're slowing down the laser, we're delivering more energy to that tissue. Moving on to question 9, do we need to adjust energy delivery parameters used based on pigmentation or race? And it was a very good question, and I get often asked this. My population that I deal with is 90+% African American and Hispanic, with some very aggressive glaucoma, and they're people of color, people with higher pigmented eyes. So the panel, some of the panel treated more Caucasian patients. There were several of us, though, that treated a large amount of African-American patients. And our consensus on this question was, it's reasonable to reduce the energy in highly pigmented eyes, but there's lack of evidence in the literature for adjusting based upon the race or pigmentation. The consensus is that with currently recommended settings, it is not necessary to significantly adjust them based on race or pigmentation, but more evidence is needed. And I think that as we go on and we've come up to some conclusions with the different parameters and how to adjust, there's going to be a lot more publications coming down the road pretty soon. And as we look at some of the old literature, there was a lot of Caucasian-based patients. And so one of my main questions was when I saw an article, well, that article is 95% Caucasian. How does that apply to the patient population that I'm dealing with? So we did our best, and we've been using the new revised probe. And I can tell you that with the current parameters of 2,500 milliwatts, 20 seconds per sweep time, and 80, and I've been going up to 100 seconds depending on the severity of the glaucoma, my pressure goals, et cetera. I'm in I think I just did my 27th in that power range. We've been slowly, incrementally increasing our power, and along with the sweep time increase. And we've had pretty good outcomes in the short term. And the safety profile is amazing. The patients, we haven't had any major issues. So to answer the question of why we don't need to increase the power or decrease the power when we're dealing with a African-American patient or Hispanic patient, I did a little bit of a literature search. The one thing is that it is true that there is a little bit of a difference in the amount of melanin pigmentation found in the ciliary body in people with brown eyes. But when on the article on the right, these are both a little bit of older pathology studies. It took a pretty long literature search to find too much on this topic. I asked a couple of ocular pathologist friends even, and they didn't really have the question. They weren't able to answer the question of, how much pigment was in the ciliary body. Because just because the iris is darker doesn't mean there's necessarily more pigment in the ciliary body. It turns out there probably is a little bit more, but the type of melanin that you find in the ciliary body is more likely eumelanin. So, and when that is irradiated, it's less likely to develop into superoxide and tissue destruction. So when people, there's more pigment in people with brown eyes, but there's less tissue. There's about the same amount of tissue destruction, which is minimal for both. That's one postulated or one theory for the reason. The other is that, going back to Dr. Johnstone's talk, and I know we keep hearing about Dr. Johnstone's talk, but it's extremely important. The target tissue here is less ciliary body, although there is some tissue destruction. Dr. Noeckert had a great article on the amount of tissue destruction and necrosis in the ciliary body, but it's significantly less in MicroPulse TLT. But so why is it working? Well, it's the target tissue is less the ciliary body and more the sclera and the ciliary muscle. So as those of us who do incisional surgery, the sclera has the exact same amount of pigmentation when we do it on a very pale Caucasian patient versus a darkly pigmented African-American or African ancestry patient. And the ciliary muscle likely has a similar pigmentation. So for me personally, I'm not changing the parameters. Most of the panelists are using the same parameters that I am when they're treating Caucasian patients, and I'm treating mostly African-American and Hispanic patients, and I'm getting very, very similar outcomes with a safety profile that's just amazing. Actually, the inflammation is gone within a week. We aren't having any major complications with the new increased settings. So we've been very happy with it. And I personally don't recommend changing these settings based upon pigmentation.
Thanks, Mike. That was great. So as Brian pulled up his slides, I think that's really compelling. And you're right. In ophthalmology, we've always associated most lasers or visible lasers, are absorbed by pigment. But you're right. This appears to be maybe a deeper tissue effect, maybe in the blood or the muscle of this lower body. And I think that's a really compelling point. And your endorsement of that, I think, is really important.
Yeah, Rob, I think specifically too, now that we're treating a little more posteriorly, and now that we're not causing the ciliary epithelial ablation, but we're having this effect on the muscle, I've been less inclined to adjust based on any type of pigmentation. So I think we're doing something different here than traditional cyclophotocoagulation.
Right, and I think you're right, Mike, and Nate, and I think that basically you and Mike probably have the most African American patients, of anybody here, certainly, probably in the world. I don't know, but I think that speaks volumes. And I've changed my treating that population. Well, I used to make adjustments, and I stopped doing it based on, and it seems my experience is consistent with yours. It doesn't matter all that much. All right, Brian.
Okay, great. So my next question is, what are the indications for MicroPulse TLT? In other words, what sort of patients are appropriate for treatment with this technology? So in looking at the literature, MicroPulse TLT can be safely performed in various glaucoma patients and in various ophthalmic-related conditions. In practice, of course, it's important to look at which therapy is most suitable for a patient in regards to the total glaucoma treatment spectrum. From clinical practice, we've seen that treatment with MicroPulse TLT can be considered in the following patient categories, and I'm going to go over these one by one. So the first one is patients who are not suitable or do not wish to have incisional glaucoma surgery. The examples include those patients that are unsuitable for incisional glaucoma surgery due to poor conjunctival tissue, so therefore the filtration surgery will not be effective or safe. Patients who are at increased risk of complications due to concomitant use of blood thinners, for example, or in the setting of aphakia. And patients with a chance of wipeout with end-stage glaucoma, or in patients that are poorly compliant, or those that cannot come for postoperative visits that you need for more traditional filtration surgery. The second group we can consider are patients who have had prior glaucoma surgery. This may particularly include patients after trabeculectomy or a glaucoma drainage device with suboptimal IOP and or the desire to use less glaucoma medication. And indeed, we found in our study that we published, we divided the patients into two groups based on efficacy, and we found a statistically significant higher efficacy in those patients that had had prior traditional filtration surgery, i.e. trabeculectomy or glaucoma drainage device tube shunt. And the next group is very simple, patients with uncontrollable IOP, either on maximum tolerated medical therapy, or those that are controlled but are intolerant of medications or are on oral carbonic anhydrase inhibitors. And next, group 4, patients with stable glaucoma on maximal drug therapy, again, including or not including oral acetazolamide, and those that have a desire to reduce those glaucoma medication burdens. And then finally, number 5, due to the favorable safety profile that we've discussed, it's really possible to use MicroPulse TLT along any of the patients in the glaucoma spectrum. So the expert consensus is to consider MicroPulse TLT basically positioned after medications and laser trabeculoplasty have been considered. But after that, really all along the treatment spectrum, from mild glaucoma, which can be controlled with multiple medications, all the way to ultra refractory glaucoma that has failed one or more filtration surgeries.
Good. So I was waiting for Ronald to get his slides up. So Brian, have you treated, in your personal experience, have you treated everybody in the spectrum? What's the mildest patient you treated and the worst patient you, or whatever?
So, so the mildest patients I've treated are basically those that are, uncontrolled with medical therapy and they don't want incisional glaucoma surgery. So they could have mild to moderate glaucoma. They're on 2 or more medications and they just, want to reduce their medication burden, but don't want, or have high IOP, but don't want incisional surgery. I've also done them on in patients that are controlled as part of a combination therapy. So cataract plus, MicroPulse in patients that may even be controlled on 2 or more medications preoperatively. And so you can consider it in those patients as well. And then probably the worst patients I've treated are those that have had, multiple surgeries, including, 1 or more tube shunts, and even patients that have had prior endoscopic cyclophotocoagulation can be treated.
Good. I agree with that. All right. Our next speaker is Ronald Crom. He's coming to us from the Netherlands, and he gets question 11. Hi, Ronald.
Yeah, hi, Rob. Thank you for your introduction. Yeah, the question I want to answer in this presentation is, what are the expected outcomes of MicroPulse TLT based on the disease severity and the baseline intraocular pressure? And if we look at the outcomes after MicroPulse TLT, of course, 2 main things are very important. First, the IOP reduction, of course, the reduction in glaucoma medications. And we also know that the expected outcomes are related with the fact if a patient has a controlled glaucoma, for example, with an IOP below 21, or an uncontrolled glaucoma with a higher IOP. And what also is important is, what are your treatment goals? For example, we all want, after a glaucoma treatment, a very high IOP reduction and also a very high medication reduction. But we also know that if you are focusing on a higher amount of IOP reduction, we could accept a lower amount of medication reduction. Otherwise, we also have patients in which medication reduction is the main target for your treatment, and we accept a lower amount of IOP reduction. There are a lot of studies done to the effects of MicroPulse TLT in the literature, and we made an analysis of the IOP and medication treatment outcomes of all of these studies. And we can divide the studies in several groups, and we looked at the outcomes in glaucoma patients with an uncontrolled IOP. In all these groups and studies, the patients had an uncontrolled IOP in which the pre-treatment IOP varies a lot. We also looked at studies in which outcomes were studied in glaucoma patients with a higher IOP above 21, and in studies in which outcomes were lower than 21 millimeters mercury. And the statement of this consensus panel is this based on the literature outcomes in the glaucoma patients with uncontrolled IOP, also in the groups with a higher amount of IOP, the lower amount of IOP, and of course also on the clinical experience of all of our panel members. So our statements in regard to the expected outcomes of MicroPulse TLT is that depending on the treatment goals, we feel that the measurable clinical effect of MicroPulse TLT is different between patients who are uncontrolled with medicines if we compare those with them who are controlled with medication. And in patients who are controlled with medical therapy, the below 21 millimeters mercury, there is a more limited IOP reduction, around 20% of IOP reduction 1 year after the treatment. But MicroPulse TLT can result in a meaningful reduction in the number of medications. In contrast, in patients who are uncontrolled with medical therapy, the patients with a higher IOP level, the clinical effect of treatment is expected to be a significant reduction in intraocular pressure, at 25 to 45% reduction of IOP 1 year after the treatment, and a meaningful reduction in medication, which magnitude will vary depending on the target IOP. That's my last slide.
Okay, excellent. Thank you very much. So Jacob, you're going to get your slides up next. We'll hear from you. So what are your outcomes? So your work is very, very interesting, Ronald, and it's made me really rethink that. So the takeaway point is it true typically, like the better the IOP the control is, the the more you're kind of leaning toward medication reduction versus when it's high, you're just happy if you get any reduction and you don't care so much about medication reduction. Is that right?
Yeah, especially in patients with a lower amount of IOP preoperative, treatment is very useful to get rid of a lot of medication, for example, oral Diamox or something like that. So if you have a patient with an IOP of 15 and a lot of medication, MicroPulse TLT can be very good in make a very good amount of medication reduction.
Good. Thank you so much. So Jacob is up next. He hails to us from Sacramento. He's one of the rising stars in glaucoma. And take it away, Jacob.
Thanks, Rob. Yes, hanging out here in the morning, you guys in the late hours, everywhere else. So I'm excited to be here. Thanks for inviting me. So I was asked the question, is MicroPulse TLT safe to be performed in various types of glaucoma? And so there's, as you can see on this slide, there's copious amounts of literature about the use of TLT, MicroPulse TLT in a variety of different glaucomas. And so as a consensus panel, we felt like it's pretty much safe to be used in most glaucomas. POAG and acute angle closure glaucoma, or glaucoma, angle closure glaucoma is pretty common, but also all the secondary glaucomas, NVG, very commonly used, obviously. Post-keratoplasty, traumatic, congenital, suexfoliation, eye syndrome, all the different types of glaucoma, it's pretty common that it's been used in these cases. Ron's going to talk a little bit, I think, next about maybe some of the things that we have to consider with some of them, such as uveitis or some of the other maybe contraindications that we at least have to think about when we're choosing whether or not to use this. And I think as we use the TLT on those patients, we do have to kind of say, what are the risks and benefits? Should I use it on a uveitic glaucoma as first line? Probably not, probably more leaning towards tubes or other things. But maybe if we've already put in 2 tubes, it would make sense to use it in those cases. So it's been used in all sorts of different types of glaucoma. Neovascular, keratoplasty, that's, I think, really an interesting area to be using it in somebody that's had PKPs or DSECs. There's some pretty good efficacy with actually very limited risk of graft failure. There's a couple of good studies on that. One of the studies I really want to talk about, actually, this is a really good study that kind of looked at a variety of different types of glaucoma. And so this is Habash et al. And this was done, and actually the settings are actually pretty high. So these are the settings, 2200 milliwatts, and it's 120 seconds per hemisphere. So this is a total of 240 seconds total delivered to the eye with a 12-second sweep velocity. So this is one of those papers where we actually got some of that data that we wanted as far as sweep velocity, even power and settings. Sometimes we don't always get that information on a more consistent basis. Obviously, this was done with the older probe, but we can look at all the different types of glaucoma and that were used in this study. And overall, it was fairly safe in all these different types of glaucomas. You can look at the the vision changes. And for the most part, really not very many changes as far as vision is concerned. That's one of the big things, obviously, we are concerned about mostly. They did say that they had 1 instance of inflammation and 4 instances of kind of those tonic pupils. But again, this is with the older probe. And personally, I haven't seen the tonic pupil at all with the newer probe, just because I think it's being delivered more appropriately to the target tissue. So I think this is a really good study that tells us, one, not only can we treat a variety of different types of glaucoma, but also that we can do so safely with fairly high settings and usually still be pretty safe. So basically, kind of as a panel, we basically decided that the studies basically showed that we can be pretty safe in a variety of different types of glaucoma, both primary and secondary. With the secondary glaucomas, neovascular uveitis, we do need to kind of take into consideration other things and obviously treat appropriately and just make sure we're taking account of the post-operative medication and monitoring and things like that. So those are my thoughts.
Thanks, Jacob. So as we're waiting for Jella Ann to get her slides up, do you think you've kind of migrated the type of patients you've done it? Like, did you start with using it like in the worst case patients, like the continuous wave transscleral? Did you do that in the beginning? Are you moving towards?
I definitely am moving. So I think 2 things that have changed. One is I'm using it in much milder glaucomas. earlier stage glaucomas, better vision glaucomas. And then also, I used to see a ton of inflammation with, continuous wave. And so now I'm using less steroids. I used to use atropine on all my cases with continuous wave. I don't do that anymore. I don't do bulbar tenons or anything like that, kind of Kenalog injections. And I don't even do a retrobulbar block anymore. And so the recovery is a lot quicker. Patients, especially like monocular eyes, they're coming right out of the OR once their anesthesia wears off, and they're doing pretty good. So definitely earlier, now that I feel a little bit more comfortable with the safety profile.
Good. We'll talk more about that in a bit. Thank you. Jella, you ready?
Yeah, the same, Jacob. I also don't do any post-op medication, or I don't do retrobulbar for MicroPulse anymore. So my question now is MicroPulse TLT safe to be performed in various stages of glaucoma and with different baseline IOP? And I'll throw in like a baseline vision as well, because there was a question here. So basically the short answer is yes. I think we've pretty much, shown how safe this procedure can be if you stick to that sweet spot of the energy delivery, and also can be moderately effective. So I really consider MicroPulse TLT as a mix of a CPC. It's almost like a separate, a very different procedure than CPC. I'm therefore an advocate of offering this treatment earlier in the disease paradigm than later. So in my experience, it really produces a better outcome when treated early and before they're put on maximal medication. This safety really allows me to treat patients with the 20/20 vision and to address the medication adherence or to reduce the burdens of medication in any stages of the disease, and also to avoid or delay the need for any incisional surgery. The level of the baseline IOP does appear to impact the percentage of the IOP lowering. It's kind of similar to SLT. As Ronald mentioned, higher baseline IOP results in a higher IOP reduction, so there's a bigger bang for the buck. But even with the lower baseline IOP, patients do get the meaningful amount of medication reduction if they are already on it. So that's when I usually offer it. So here's a case of my own patient illustrating this point. This is a 75-year-old Caucasian female, still working full-time, very active, very healthy. She has a POAG pretty mild on the right side and moderate on the left side. You can see it on the visual field. She had a mixed surgery in the past, but still required 2 classes of medication to keep the IOP in a target level. However, recently she could not even tolerate that anymore. So now she can't tolerate any of the topical or oral medication. Pressure is now up to 24 on none, and now she's coming in with signs of a progression, this cheme. And so we talked about the filtering surgery as a next step, but she was very adamant that she does not want any surgery because, she's living 2 hours away. She's the only caregiver for her ill husband. There's a lot of lifting involved and can't afford to take any days off more than a week. So she's very adamant that she can't have a surgery. So thankfully, the MicroPulse TLT to rescue, we decided to proceed with the MicroPulse in a good eye first, because my logic here was that if she didn't respond sufficiently in the better or milder eye, then we're not going to waste any time with the little more advanced eye. And I was feeling completely comfortable offering this procedure with the milder disease eye. So we use a 25, basically what's recommended here, 2,500 milliwatts, 160-second duration, so 80 seconds per hemisphere with a total of 160 seconds, spending 20 seconds per hemisphere sweep. At 1 week, usually it takes several weeks for the pressure to effectively lower, but already at 1 week, pressure is down to 19. It was pretty good. She was having absolutely no issue, and she couldn't wait to get the other eye done. So with the other eye, given that it was a little more severe disease, I increased the duration to 100 seconds per hemisphere. So that gets closer to that sweet spot. It's actually 150, I think it's 155 joules of a total energy delivery when you use 100 seconds per hemisphere. And then she had a pretty good reduction, a 33% reduction of the IOP from 25. with the final IOP of 18 and 16, and she enjoyed a significant improvement in her ocular surface and even better quality of vision. Oh, here we go. So that's how we apply the video, but I think we are going to show the video again so we can move on to the next slide. Next presenter.
So what kind of anesthesia? So next up we have Ronald. So what kind of anesthesia do you use for the actual procedure?
So patients are sedated, usually a little bit of a propofol for 5 minutes, and I don't use any retrobulbar or peribulbar block. I do use a lidocaine as a coupling agent, but that's about it. And patients really like that because they don't have to wear a patch. And they said it's actually more comfortable when I don't give them peribulbar block than, because I think of those patients who do get the peribulbar block, they get like a little bit of a bruising there, and then that becomes uncomfortable. So there appears to be no like a late pain associated with this procedure.
Were her eyes a little less red?
What is it?
Were her eyes less red after this procedure?
Yeah.
I hope. Oh my gosh. Mark, are you ready to talk to us? And you have your slides up to talk to us about pediatric glaucoma?
Yeah, I'm ready.
Okay. Share, yeah, your screen. Good. All right, take it away, Mark. We're switching the gears here a little bit, talking about a different population.
So it's actually two questions that I answer in the next question 14. Is MicroPulse TLT a therapeutic option in pediatric glaucomas and also in adult glaucomas? If we look at the evidence, the age of a patient plays an important role in the surgical treatment of glaucoma. For example, in younger patients, the duration of treatment effect and the possibility that additional glaucoma surgery during the lifetime of the patients may still be necessary in the future should be considered. For pediatric patients, only 3 studies investigated the effect of MicroPulse TLT in these patients under the age of 18. Although treatment with MicroPulse TLT appeared to be safe in these patients, the results showed a higher number of retreatments and failure in comparison with the results in adult patient groups. So in my own experience, I still do MicroPulse TLT in pediatric patients. For example, we sometimes see this really young babies that are born, and you have to talk to the parents of these patients for the first time about the disease. And most of these parents don't even know that glaucoma can occur in a baby. And they have like this phase where they're kind of shocked, and you have to talk them over this moment, but still try to convince them that surgical treatment for the baby is necessary. And that's like a tough phase for these parents, for the whole family usually. And sometimes in these babies, both eyes are affected. And in my population, I often see parents who agree like, okay, do one surgery in one eye, but then you have to talk to them, what's with the second eye? Because the pressure is also very high, and we have to get it down. And then MicroPulse TLT for me is a really good option because I can tell them it's a safer laser procedure. It has limited efficacy when it comes to time. So compared to adult patients, I don't see the efficacy for like months, years. It's more like a short period of time where the pressure is reduced, but still I can do the operation, the surgical operation on the one eye, do MicroPulse TLT on the second eye, and give the patient and the family, mostly the family in these cases, some time to get used to the idea that the baby is not completely healthy and needs multiple surgeries in the future. And after the first eye has healed a little bit, the MicroPulse TLT has lowered the pressure in the second eye. Maybe the effect of the MicroPulse TLT is already fading out after some months. Then the family is ready to agree to the surgery in the second eye. So for my personal experience, that's like a really good option to bring MicroPulse TLT in this baby group, in this pediatric group of glaucoma patients, even if the efficacy time-wise is limited in effect. In elderly patients, it can be difficult to perform glaucoma surgery because of other comorbidities or because the quality of the ocular tissue is insufficient for perform a surgery. Like, for example, the conjunctiva is scarred and you have problems doing a trachelectomy or even a tube shunt in these patients after multiple surgeries or other diseases the patients have. In literature, treatment with MicroPulse TLT is reported mainly in adult patients with glaucoma. These different studies show that MicroPulse TLT is a safe option, treatment option for these patients of 18 years of age or older. So to summarize, MicroPulse TLT can be performed safely in adult patients with glaucoma. In pediatric patients with glaucoma, MicroPulse TLT appears to be safe, but because of the limited data, remember only 3 studies that I talked about, and possible higher number of retreatments and failures, we recommend further clinical investigation to the effect of MicroPulse TLT in pediatric patients.
That's good. So as Ronald gets his slides up, so do you do traditionally still like goniotomy or trabeculotomy as a first line in primary patients?
Goniotomy usually 360 degrees. It's like the first line treatment in my personal algorithm.
And would you put this second?
Sorry?
Would you put this, if that failed, would you put MicroPulse second?
Well, as mentioned earlier, it really depends on the family, if you talk to them and how they feel towards surgeries. I actually do it often second because, as mentioned earlier, these families usually need a lot of time to get used to the idea that their baby is sick. Mm-hmm. And I only can kind of imagine how it would feel, but I think it's really tough to get used to that idea. And if you look at these little babies and their first 2 decades of life, I mean, they have not only 2 or 3 surgeries, they often have much more. So I think it's a good option, and that's why I bring it up often and perform it often as second line surgery, because it gives them time to calm down, and still you as a surgeon feel safer and kind of more convinced that you can bring the pressure down meanwhile to at least a safer degree, even knowing that another surgery will follow later. Yeah, I do it as second line surgeries.
Those are really good points. Does anybody else have experience in pediatric glaucomas with this?
I've had a few of like teenage JOAGs, moderate success, usually, a year or so, maybe a couple of years. Overall, it's a good alternative to incisional surgery and just delay things. I mean, any juvenile or pediatric case, you're just buying time. You've got to treat them for 60, 70 years. So anything to add to it.
That's a good point.
Exactly.
All right. So Ronald's going to talk about where we fit MicroPulse in the treatment algorithm. Ronald?
Yes. Can we perform MicroPulse TLT before or after incisional surgery or glaucoma drainage device implantation? And we all know that if we treat someone after glaucoma surgery with MicroPulse TLT, it is important to avoid the areas of trabeculectomy and to avoid the areas in which the glaucoma drainage tube is. So therefore, we analyze the literature to see how safely it is to perform MicroPulse TLT in these cases. And if we start with MicroPulse TLT after trabeculectomy, we see a lot of studies treated patients who already received a trabeculectomy. And in all these studies, it seems that there was a good safety profile of MicroPulse TLT in patients who were treated with MicroPulse TLT after trabeculectomy. And if we look in patients who already have the glaucoma drainage device, also there are a lot of studies who treated patients with MicroPulse TLT after a glaucoma drainage device. And also in all these studies, a good safety profile of MicroPulse TLT was present. There are also some other glaucoma patients, of course, with other glaucoma devices, but there is less literature in these cases. Our own group investigated MicroPulse TLT in patients after a Xen implant or PraserFlow. There are also some studies in patients after GUT procedures with the trabectome, and also some MicroPulse TLT after iStent implantations. All seems to be safe, but low number of treated patients. If we look at MicroPulse treatment before glaucoma surgery in the literature, we see that MicroPulse TLT has been used as a first-line surgical treatment also in quite a lot of studies. And also in all these studies, there was a good safety profile in the patients who were treated with MicroPulse TLT. There were no specific publications on effects of MicroPulse TLT on the outcomes of subsequent performed glaucoma surgery. But in my own clinical experience is that grafts and tubes can be safely done after MicroPulse TLT. There is, for example, no conjunctival scarring present after MicroPulse TLT. So the statement of our panel is, if we concern the safety of MicroPulse TLT after or before glaucoma surgery, MicroPulse TLT can be performed very safely in patients with glaucoma after prior trabeculectomy and/or glaucoma drainage devices. And MicroPulse TLT appears to be safe prior to incisional surgery based on the clinical setting. Although at this point of time, there is a need for more publications on the indication of it.
Thank you, Ronald. So as we're waiting for Brian Jerkins to get his slides up, for you, Ronald, where do you use it most commonly? So what's your number one place or most likely place you're going to use it? I'm sure you
yeah, probably both the indications. So patients who already had a trabeculectomy or glaucoma drainage device in which you want some more IOP reduction, and they are very suitable to perform MicroPulse TLT. And also patients who are a little bit scared for glaucoma surgery, in which you think you want to postpone glaucoma surgery, they are also very suitable to first treat with MicroPulse TLT.
Good. I'm kind of with you. I agree. Good. All right. Brian Jerkins comes to us from Tennessee. Brian, you ready?
I'm ready. I'm ready. Well, thank you for the opportunity to talk to you. I come from Memphis, Tennessee, so I'm one of the locations that treats a lot of patients with more active inflammatory and a lot of African-American population when I use MicroPulse. And we've talked a lot about the safety and the efficacy of this, but are there any contraindications or cautions in some of the MicroPulse patients when it comes to what patient characteristics we might want to avoid using this treatment? When we look at the literature and from the panel, we believe caution should be exercised in patients who have a history of scleral thinning, which is a very difficult population to treat when it comes to more traditional trabeculectomy or tube shunts. Basically keeping in mind the underlying pathophysiology a lot of these patients with thinning might have, whether it be autoimmune disease or whatnot. The MicroPulse can, though, still be used in patients who have some thinning and just avoid those areas of thinning. And we'll look at kind of how much thinning you should look for in some of these patients. A lot of times, if you can find a patient who has a very limited area of thinning and you avoid that clock hour, maybe it just be 1 clock hour or less, it still can be used safely. Another very common patient population that I deal with is patients with uveitis. So patients at a very high incidence of inflammation and can be a very difficult pre and post-operative management patient population. So here's an example of a patient in my clinic with scleral thinning, and he does have a little bit more than 1 clock hour in that superior temporal area, but care should definitely be avoided taken when using MicroPulse in areas of scleral thinning. With an area of scleral thinning, we've looked at the mechanism of how this works. You can get some increased amount of energy penetration compared to a thicker scleral patient. So some of the complications can occur due to a higher treatment. So you may want to consider avoiding areas that have thinning if it's more than 1 clock hour. If thinning is associated with rheumatoid arthritis, you may want to consider avoiding. And also areas that have previous thinning with mitomycin C. So as mentioned, we want to avoid areas that have had previous trabeculectomy or a tube. Our patients with uveitis, as we've talked about before, oftentimes this is first-line treatment is very likely going to be an OMED valve for patients with uveitis, but this can still be used in some of those patients, whether it be adjunct or prior to a tube surgery. But you want to do this on patients who are quiet. So try to quiet down the uveitis if at all possible. Consider a lower treatment duration for these patients especially in a lot of the patients that I deal with, a lot of our African American Hispanics who may be a little bit more prone to develop inflammation as well. I treat a lot of these patients also very aggressively with steroids compared to a normal MicroPulse patient. So I may pre-treat with some topical steroids a few days before. I often will give subconjunctival steroid injections, usually dexamethasone at the time of surgery. Occasionally, if it's like a sarcoid patient, I may even give them IV or an oral course to try to ensure that they'll be quiet. And also can watch them very closely during post-operative. We've talked about how it's a very safe, minimally inflammation type of procedure, but some of our uveitis patients may need a prolonged steroid course. In cases of active uveitis, even though it may be tempting to try to aggressively get the pressure down, this is a situation where you would want to avoid MicroPulse if at all possible.
Okay, thank you. So before we're going to move on to our presenting the case sections, just to kind of bring home some of the points, but why don't we just take a minute to ask everybody like 1 30-second soundbite what you've kind of taken away as or changed in your practice as being part of this consensus panel. Brian Jerkin, since you spoke last, we'll let you speak first this time. Is there anything that you've changed or recommend, any pearls you want to give us?
My biggest takeaway has been I've slowed my sweep time down. I've been using this now, I don't know, 6-7 years since it first came out, and was very comfortable using the technology, but was getting a little frustrated with my results. And I guess I was a little slow to adopt higher power and slower sweep time. And once I've done that, being a part of this panel, really have noticed increased efficacy and results with it. So that's the biggest takeaway for me.
Great. What about you, Ronald?
Yeah, 2 parameters, the use of a higher amount of energy. With the revised probe, I think all of us noticed that that you have to use higher energy levels to get good results, and also the sweeping time. So the sweeping time of 20 seconds, I use it standard in all of my patients to begin with.
Mark?
Yeah, it's basically the same. I mean, the sweeping time for me made the biggest difference. So going from 10-second sweep to 20 seconds really increased significantly the results that I got. And as I mentioned earlier, I treat really carefully, usually with like 2000 milliwatt. I now changed also 2500. And with the 2 settings together, still having the safety profile that is amazing, having better results was for me the biggest change. Another point that maybe was not mentioned yet, and when I first started using MicroPulse TLT, I didn't think about it as well, is the coupling agent. So I try always to use a gel to have enough fluid interface between the laser probe and the globe, basically. And for me, it's pretty easy because I use topical anesthesia with a gel. So I always have the gel on the eye. Otherwise, when I have patients which kind of have like other forms of anesthesia, I still use a gel as a coupling agent to keep the laser from spreading and have the energy really delivered to the tissue where I want to have it.
Okay, that's a good pearl. What about you, Jella?
I think the real advantage of the MicroPulse TLT is its safety. So although, we have this consensus of where the starting point is, and I agree with that, but it's important to optimize based on your surgeon factor and your patient factors. I think there is a, potential to go get more effective IOP lowering with a slightly higher energy before you reach that threshold of a safety, compromising the safety. So we still don't know exactly where that spot is, but I think you can, start with what we recommend first, which is the 80-second per hemisphere, and with the 2500. And then, see after several, after about 20, 30, then you'll get a pretty good idea whether you can increase it or decrease it. And yeah, as we talked about, those patients to be careful are really the uveitic patients and scleral thinning patients.
Good. What about you, Brian Francis?
So, I of course agree with what the other panelists have said, but I'll also mention repeatability. I think, I'm more likely to repeat treatment in two different types of settings. The first one is a patient who's been treated and the effect is worn off over a year or more. I'll retreat them generally with the same parameters. But I also will now retreat patients successful at pressure lowering initially, but just increase my parameters. I feel with the better safety with the version 2 probe, I'm more comfortable increasing those parameters, to 2750 on power, slowing the sweep rate to 20 seconds, and increasing, up to 110, 120 seconds per hemisphere. I'm very surprised, or not very surprised, but I'm pleasantly surprised by how less of side effects I'm seeing with version 2 probe versus version 1 probe, even with these higher parameters.
I agree with you. Those are good points. Mike Javingo?
I'll probably just kind of echo some other, statements, but the one thing that came to me from everything we've been doing is that how safe it is at the current parameters, and that maybe we still are even under treating a little bit. I've been going all the way up to 100 seconds per hemisphere. And honestly, besides me, I've been getting the same input from everybody else that the side effect profile is amazing, even at these, 2,500 milliwatts, 20-second sweeps, 100 seconds per hemisphere. So maybe for the more aggressive patients, the higher pressures, maybe I should even be treating higher. I don't think we've reached the sweet spot, or at least we're getting to a dangerous level, because I'm not seeing much inflammation at all. And I think that was one of the main consensus findings.
Yeah, no, I agree. And Nate?
Yeah, well, the thing I like about this probe is just how you can tailor it to, the treatment to every patient. And I could change my settings based on a discussion with the patient heading in, hey, if I have to do this again, would you rather, I go lighter the first time, or is this the only time you want to do this? Their answer will determine, what power setting I choose. I think, I've tended to go with higher powers and lower duration. And so I'm kind of adjusting my settings towards longer durations, but I've pretty much kept higher settings. So 2,500 is now the lowest that I use with the new probe. And I do go up to 3,000. I hope, it's not going to make anyone in the room uncomfortable, but, I have some very tough glaucoma patients. And, sometimes you just, when the pressure is 65, it's not uncommon for me to treat that kind of pressure on everything. I feel like I really, the least safe I could do is, thing I could do is under treat in some of these eyes. So, but again, just the ability to vary all these therapies. I do always give subconj steroids. For me, that's mandatory.
Dr. Grippo?
Well, I agree with everything the other panel members had to say. I think this consensus process really helped us get a structure on what we do, in a sense, homogenize more what we're all doing, and also give us that structure to treat patients more aggressively in the future, or a little bit less aggressively, and it also has helped us understand better the literature. A very heterogeneous, challenging literature that's out there makes, I believe, much more sense when you take into account all the concepts we will discuss today. So I hope and foresee that this will be a stepping stone for better evidence, better publications, better rationals for this technology and in the scientific community in the next future.
I agree. I think that's great. So Mark, can you pull up your case slides?
Sure.
And then for me, I agree with everybody said. I think we can be more aggressive. And for me, I'm on a trek to see how slowly I can make my sweep speed. So this is like my new source of entertainment, is how slow can you really sweep that probe. So I always start with the 20, but when I up it, I'm going slower and slower and slower. So we'll see.
One important thing, Rob, is the fact that these are the recommended settings from this consensus panel. And this is what we feel is safe, for people to start using. When they want to go up just increasing 20, 25%. And that means, I mean, you can go up from 80 seconds to 100 seconds per hemifield. That's already a 20% increase, 20, 25% increase in your overall energy delivery to the eye. If you decide, like Nate was saying, just to increase the power, you know, if you go from 2.5 to 3, I mean, you're also going up, you know, 20%. Just don't do it all at the same time, because, you know, or even if you go, you know, up or down with your sweep velocity, that will also have that impact. So just go in order, you know, probably follow this rule of thumb kind of approach we are suggesting, and we'll go from there. We see, you know, what the future shows.
Yep. Our recommendations, you know, 2.5 watts, 20-second sweeps. So, okay. Mark.
So after all the questions we did for everybody who is still online, I give you the first case presentation today. These are my financial disclosures. Some are related to this talk. And the first case is a case of mild glaucoma, 69-year-old male Caucasian. So primary open-angle glaucoma - normal tension glaucoma on no drops, a little bit thicker than average central corneal thickness, and a 20/20 vision in both eyes. Patient is still phakic. And detected on RNFL OCT, we saw progressive RNFL loss in both eyes. We did diurnal IOP curve, which we sometimes still do in a hospital setting in patients with normal tension glaucoma. We saw a mean IOP of 16.4 in the right and 15.8 in the left eye, in both eyes with a range of 14 to 25. So it's discussable if it's normal tension glaucoma, because we actually have IOPs in the supine position that is above 21. The patient in both eyes had some defects in the visual fields already, with an MD of 5.0 and 4.1 in the right and left eye, respectively. And as most times in these cases, I discussed topical therapy with the patients, but I have a group of patients which is really well informed about the disease and about treatment options, and it's really critical. And for this patient, topical therapy was not an option due to the potential decrease in quality of life for him by the drops. He read about like redness around the eye, eyelashes that get thicker and longer, and he didn't actually want any of the treatment. Alternatively, I discussed SLT with him. He also, at that point, was aware of what SLT is and agreed to be treated with SLT in both eyes, first in the right eye and 2 weeks later in the left eye. The pressure was reduced to the low teens during office hours with stable RNFL in the follow-up visits. And later on, the IOP increased to the mid-teens. 2 years later, he received a re-SLT in both eyes. Thereafter, the IOP was again in the low teens. Earlier this year, I saw the patient again, and the pressure was up to the mid-teens in both eyes again. Visual acuity was still 20/20 in both eyes. The patient was still phakic. And I saw a new RNFL loss in the left eye that was reproducible in OCT after 4 weeks. And as you can see in the scan of the Heidelberg OCT, there is a new RNFL accurate loss of the left eye. So we discussed re-SLT as another option. It would be the third SLT. And for me, it's questionable to do a third SLT. Would it achieve the IOP lowering efficacy that I would need in this patient? And how long would the effect last again? Alternatively, we discussed starting topical therapy again. Well, was the same. The patient refused topical therapy, again, to the potential decrease in quality of life, to the side effects, but also to the fact that the patient had to take the drops every day. In a patient with a 20/20 vision, no drops, early glaucoma or mild glaucoma, for me, incisional surgery is not a treatment I feel comfortable with. So as an alternative, I discussed MicroPulse TLT in the left eye with the patient as a second alternative treatment option to drops after SLT. And he agreed to the MicroPulse TLT in the left eye. It was performed under topical anesthesia with lidocaine gel without any complications. The settings were 20 seconds per sweep, 80 seconds per hemisphere, 2,500 milliwatts, and the average duty cycle of 31.3%. The IOP decreased by approximately 35%. And at the last visit, which is now 8 weeks after the RNFL loss was detected, the IOP in the right eye was still in the mid-teens, 15, but there was any there wasn't any RNFL loss detected. In the left eye, it went down from the mid-teens to 11, still on no drops. And the visual acuity remained unchanged with 20/20 in both eyes as a phakic patient. So for me, in this early glaucoma cases, MicroPulse TLT can be performed safely. The visual acuity didn't change in this patient, even with 20/20 vision. Some questions came up if you can perform MicroPulse TLT in a phakic patients, or if you have to be worried about cataract formation. Well, this patient was phakic, and there's limited evidence actually if the cataract can progress after MicroPulse TLT. But in my personal experience, it does not significantly faster progress than in the other untreated eye. So thank you for your attention.
Thanks, Mark. No, those are really thought-provoking case because it's not the tip. I don't think it's the typical case we think of for MicroPulse. On the other hand, it works.
I know.
Right? Do any other panel members have experience or opinions about that? I have. I've done it in a couple similar patients, and it's good to hear your experience because I find the same thing for patients. You know, there's some people medical therapy is just not going to cut it, and I think the other spectrum is there's other people that surgery's just not going to happen either. So I think it really fulfills a nice niche. And once again, going back to the newer probe, I feel much better, and I think it's much less likely to have problems and have a much better safety profile.
I think another situation is also patients that are, older, not wanting to do incisional surgery, or, dementia or something like that. And so I think even though they might have really great vision, I think this is a great situation where you can use it in those cases and avoid tubes and things like that. So I think even though, younger people, we might do it, but also older people that can't take drops and their family's worried about some issues and things like that, I think it's a great option for them too.
Rob, further developing on, on Mark's comment on cataract formation, there's this very nice paper from Barikuti, who actually looked at cataract formation after the procedure. And once you dissect, all other possible causes of decreased vision, the rate of cataract formation was, if at all, pretty low. And, like you were saying, with a new probe that's actually aiming, you and Brian, that's aiming more posteriorly, there's probably less photons hitting the lens, if that's the mechanism. So even less likelihood of developing cataracts.
Good points. All right, so I'll present a middle of the road case. And for me, I would say that in my population, this is probably the most typical place I use, MicroPulse TLT. Is kind of someone who failed like MIGS, or in this case, the patient had a Zen with kind of lighter level glaucoma surgery, on multiple 3 active ingredients, 3 medications, already pseudophakic, significant visual field loss, one eye worse than the other. The Zen had worked in the one eye, the worst eye, fortunately, but the other eye basically failed. It was a Zen failure. She was right back to baseline. Pressure's 25 in this left eye. With the right eye, fortunately, thought at target, so that she did one more procedure. And, the question is, do we go on and do a trabeculectomy? Do we go on and do a tube, or we do MicroPulse? And so in this case, we chose to do MicroPulse using the settings that we've come to as a consensus panel, 2.5 watts, 20-second sweeps for 80 seconds per hemisphere. This is a typical treatment. Once again, very straightforward. I tend to still block my patients. I do them in the OR. I don't actually block everyone. I do them in the OR though. I'm backing off of my blocking, just as our younger panel members had suggested, or our smarter panel members had suggested. So uneventful, and we got her basically to an equivalent result as I achieved with the Zen in the other eye at 6 months, and she's doing quite well. And she's on one medication in that left eye, which I think is, as we've talked, very consistent with kind of experience. I think is Ronald brought up in his analysis as well. Anybody have any comments on? Do you think this is like kind of a middle of the road case? This is like, I think, just right down the middle. Comments, questions?
I think this is a perfect case. I think, I think this is kind of our go-to. A lot of times something fails and we're moving on to something else. And in this case, it's probably either a tube or this. And I think you got a great result. And I think that's pretty common. Kind of bread and butter right here.
Yeah, this is right down the middle. So if you're wondering where to use it, I think this is it. All right, so let's go to Mike Javingo on the other end of the spectrum.
Yeah, we'll go over to my usual patient. Let's see, why is it not advancing? Okay. So this is a patient, a 61-year-old African-American female who is well known to our service, has had end-stage glaucoma for over 15 years. We've been treating her moderately successfully for that time frame. She came to us with loss of fixation, but we have maintained her vision. Cup to disc ratio 0.99 for many, many years, both eyes. CCTs thin, which is usual, especially thinner CCTs in an African American population. So wherever our pressure is likely we're not estimating it properly. And then the patient underwent a trabeculectomy with mitomycin C in the right eye in the 1990s at Outside Hospital before she came to us. And then the right eye also, about a year and a half ago, we did a MicroPulse TLT with the original probe a year and a half ago with pretty good results. She's been controlled up until now. And the left eye had an express shunt R50 10 years ago. So on the preoperative exam, she's 2400 in both eyes, which has been her baseline for some time. Pressure of 21 in the right eye, 18 in the left eye. The bleb in the right eye it's sidal negative, but it's flat. There's iris plugging. Sclerostomy hasn't been working for some time. And the left eye has a low-lying bleb, sidal negative. The express shunt is in place. Somehow a lot of those end up eroding, but this one stayed in its place. She's on latanoprost in both eyes, dorzolamide, levobunolol, brimonidine, but we didn't add Diamox due to a sulfa allergy. But my personal thoughts on the Diamox is really just a bridge. Even if she got to goal, I don't like keeping people on it for any long period of time. Visual fields, as you can see, quite advanced. She's lost fixation in both eyes, hence the 2400 vision, but overall pretty stable, kind of a hard visual field to follow for progression though. OCT, again, very advanced. You can see these tilted nerves that are quite prominent RNFL loss in both eyes. So we talked to the patient about the right eye, given the fact that that was the one with the pressure at 21, and discussed, I said we could put in a Bearvelt 350 or we could try the MicroPulse TLT one more time. And this patient opted for the MicroPulse TLT. I generally, in these cases, I give them both options. I kind of talk to them about, the efficacy of the Bearvelt 350 it's well proven. It's it's just a lot more to go through, especially in somebody who's already had a previous incisional surgery. But I don't think anybody here is going to deny that the Bearvelt is a great alternative or great treatment option. It's just a whole lot to put a patient through. So she opted for the MicroPulse. And I performed it. Let me see. That's right. Sorry, slide's incorrect. That's supposed to say right eye. I'm like, wait a minute. We've been talking about the right eye the whole time. So we performed the MicroPulse TLT with the Revision 2 probe. The standard settings that we've been talking about: 2,500 milliwatts, 31.3% duty cycle, 80 seconds per hemisphere, total of 160 seconds, doing the 20-second sweeps. Actually, in retrospect, if I was to redo this patient after our discussions, which this patient was done back in February, I would actually prefer to have done more like 100-second treatment for her, just given the fact that I need her pressure down into the 10 to 12 range. I did it with IV sedation anesthesia. Rob was kind of talking about that earlier. I have gone completely to IV sedation unless there's a patient that is in for some reason can't go through IV sedation, obese, multiple comorbidities, or just in the clinic and really needs something immediately. Sometimes in neovascular glaucomas, I'll block, but for the most part, the general patients, I bring them to the operating room and do them with no block whatsoever, just topical lidocaine, which it's been another thing that I've run into a lot of people just in discussion about why is it not working for me and that sort of thing. You have to use a coupling agent. It's absolutely imperative. If you don't have a coupling agent, you're just not delivering as much of the laser energy to the eye. So absolutely imperative. So post-operative, of course, day one, pressure was 14. Another thing that I always see them post-op day one, just kind of for hand holding, but a lot of people wait until week one. But if for the vast majority of my patients have a pretty low pressure, at least on post-op day one, whether or not they're successful or not. If you're not getting the pretty low pressure, I would consider, something about technique as far as your success. I usually keep the patients on all of their drops immediately after the procedure because they don't have to patch. But this patient, for some reason, didn't listen, just didn't take her drops, but the pressure was 14. So instead of putting her back on all of her drops, I just restarted the latanoprost to see if maybe we could get her off of a few medications as well. She came back post-op week one with a bit of an elevated pressure. She was all the way up to 26. Vision was a little bit down. That might have just been an effort thing. So I restarted all the regimen that she came in on, which it highlights another point of whether or not you're having the post-op day one, whether that's a sustained effect or not. But we put her back on the regimen that she went into surgery on, and we got a pressure of 9. Went all the way out to post-op month 5 so far, and I think I'm seeing her within the next few weeks. But vision remains stable. We have a pressure of 11, good sustained effect, and hopefully she remains there. But she's doing well currently and very happy with her choice as opposed to doing the Bearvelt. So thank you, and I guess that I'm the last case of the day. I get that honor.
It's an honor. It was an honor. That's a great case. That's a tough case, and it's impressive when you look at the efficacy it delivers. That's like,
yeah,
that's amazing. That's like that's the last Custer's last stand there kind of thing.
Yeah,
that's great. So everyone's been great. I want to appreciate everyone's time. So we have a few closing comments from our fearless leader, Dr. Grippo, and then I think we'll wrap this up. Dr. Grippo?
Well, thanks so much, Rob. Thank you everyone for joining us today. We hope this webinar has helped you reinforce some of the important concepts about MicroPulse TLT therapy. We hope that soon this work we've done will be published and become available as a reference for future publications. We invite you to join us in the next consensus chapter, which will be around the time of the American Glaucoma Society meeting this early next year, on the remaining topics that were not addressed today. And lastly, if you have any further questions, please submit it to info@iridex.com. Thank you so much.